Hi, Dr. Mrema. We can't hear you though.
Yeah, he's muted.
Hello.
Hey, how are you?
I'm fine. How are you?
Fine, thank you. Thank you for coming. Yeah, we're just giving a few more minutes.
All right. Thank you for inviting me.
Oh, you're welcome.
Okay.
Yeah, so Mr. Jakaben, Dr. Mrema is from Tanzania and he works in the burn unit.
Oh, okay.
So he's surgeon, plastic surgery, right?
Yep.
Yeah. So, and Miss Victoria is going to join in shortly, and she just texted me she's coming in. Yeah.
Okay.
So let's just give a few more minutes and then see we can start. Dr. Gwen.
You got him?
Yeah.
Okay.
Does it pop up on your screen?
Yeah, it does.
Okay. They're coming in.
Yeah, I didn't see Dina. I mean, I know she logged in, but I didn't.
Hi, Miss Victoria.
Good morning. Good morning.
Guess who is here?
Oh no.
Yes, you're in trouble today.
Oh no. Good morning, sir.
Your name is right there.
I dressed for the occasion. Y'all see my pen?
I can see it. Okay, now.
Remember?
Yes.
Zanzibar.
I remember Zanzibar.
Yeah.
Right.
Yeah, you should come back to Zanzibar. More shopping.
Me?
Yes.
I don't know. I will make it. I will make it a point to get there.
Yes. We will eventually go back. Good morning,
Morning.
Dr. Gwen. How are you?
Morning.
Habari ya asubuhi. We got Missy.
It's not working. That's nurse practitioner, Missy, yeah? Oh, good. Yeah, so one moment and then we can start, but I know people have things to do. Hey, Dr. Gwen, how is the conference? Dr. Gwen, can you hear me?
Good morning, everyone.
Good morning. Good morning. How are you?
Good. It
How was the conference?
was great. Cold, very cold.
Oh, it's very cold.
Yeah, it was like 11 degrees.
Oh my goodness. And we had 90 here to share.
Yeah.
Thank you everybody for coming and welcome to the KARIBUNI Qhsc discussion planning meeting. So we are planning for 2022 medical mission, and then we are so excited. We have an ambitious schedule for the medical mission. This is going to be big, and we got all these global experts who are willing to spend their time and share their knowledge, and then go and educate and train healthcare workers in Tanzania, and engage in community outreach. So we have a couple of areas that we are going to do for community outreach. But to start with, we're going to start with acute setting, which is the hospitals, things that we're going to do in the hospitals. So throughout the meeting, and for those who can stay from the beginning to end, that would be great. And I know for some of you have already asked to join in and leave because you have prior arrangement, that's fine. So we are going to discuss things that we can do in the theater. I mean, Tanzania calls in theater, but you know, US we said operating rooms and procedures. Or and then so we have esteemed expert Dr. Gwen Randall, who is anxiously is going to help us to provide her expertise in that area. We have, we're going to discuss about the NICU and the OB. So usually, and as soon as we discuss the NICU, you have to discuss the mom because where the baby is coming from. And then so if you have to help the baby, you have to help the mom. So all those things are going to go together. We have the pediatric screening. Of course, those kids who are worried about, they're going to go up. And so we need to discuss things that we can do for the pediatric population. We have the eye screening and in schools. So thank you very much, Dr. Vanessa. Is she there? Thank you for volunteering and wanting to go with us in the medical mission to do the eye screening and the vision screening for these children. And then, of course, these children also are going to experience some burns. So there we have Miss Victoria and Dr. Mrema here to help us in those areas. So, so just to give you a background, the goal of this meeting is just to see logistics. How are we going to do those education? Because we want to be able to do the education before we get there, like either it's monthly, if it's feasible, or every other month. And then we have to have a cooperation from United States and in Tanzania. Meaning, like, for example, if Miss Victoria wants to do a training for burn, then for Dr. Mrema and the other people in the burn units, how are we going to collaborate that training? So it's something like that. So if we have Dr. Gwen Randall here with the operating area, so Dr. Benella, she's going to come in, and then also she's going to be on Tanzania from Mwananyamala. So there's a lot of things that we need to do. But to start with, we want to make sure we know who is here, and so we can communicate with each other. And without forgetting Miss Inori is our nurse practitioner from Ohio. She's here. She's going to try to help us with neonatal resuscitation. So when Dr. Robert gets here, we introduce with him because he's on the NICU on the side of the Tanzania. Okay, so let's start with Mr. Siakabe, if you can give a little introduction just so you know who you are, and then everybody else is going to go, and then you can start discussing.
Good morning, everyone. Good evening, I guess, if you're TZ time. My name is Parang Siakabe, and I am a member of QHSC. I attended the mission last year as the cameraman. I'm assuming I'll maybe have a larger role this year, not in healthcare, as far as I know, unless there's an emergency and I have to jump into action. But other than that, great to meet you, and it's good to see you all again. Thanks.
Ms. Victoria.
Hi, my name is Victoria Jones. I am a wound care specialist, and I am also a member of QHSC. Got a chance to meet Dr. Memra last year. I really enjoyed that visit, and looking forward to coming again this year.
Thank you. Dr. Gwen Randall.
Yes, I'm Dr. Gwen Randall. I'm a nurse anesthetist, been in practice for about 25 years and very heavily involved in academia and missions.
Thank you. Dr. Mrema.
Hi everyone. I'm Dr. Edwin Mrema from Tanzania. I work with Muhimbili National Hospital. I'm a plastic surgeon. I just qualified last year and graduated last year. And happy to have you to have invited me, and it's the first time meeting all of you. And I met Victoria last time when she came to Tanzania, and she visited our clinic and she came to our ward. And I'm very happy to see you all. Thank you.
Thank you, Dr. Mrema. Dr. Vanessa, thank you.
Hi, everyone. I'm Dr. Vanessa Stenville. I'm an optometrist. This year actually makes it 30 years. Very happy, yeah. Like
Wow,
30
you said it when you were 10 years old?
No, and really happy to be part of this mission. I've been doing mission trips for the last 12 years. The first time with you guys, and just praying that I could, make a difference. My slogan has always been to help people see the world that they love better, but to see Jesus even better. So I'm hoping that that I could accomplish that goal.
Thank you, Dr. Vanessa. Hi, Dari. Yes, thank you.
Oh, perfect. Sorry. I apologize. I was trying to get it unmuted. I'm on my cell phone. So I'm Missy Nuri. I'm a neonatal nurse practitioner. I work in a newborn intensive care unit in a level 3 in Cincinnati. I was not on the first mission trip, but I'm looking forward to the one that is coming up in September. I'm looking forward to anything I can do to help providers learn how to resuscitate and stabilize newly born babies.
Thank you very much, Missy. Mrs. Behuniak, Christine?
Can you hear me?
Yes.
Okay, all right. I'm also having trouble with my Wi-Fi today, so I'm doing the best I can connecting with you. But my name is Kristen Behuniak. I'm a teacher. I've been on 2 previous mission trips, and my hope is to help with the education with the children and the communication. Gina Langu ni Kristen.
Very good. Tunafurahi kukufahamu. There she is. We can hear you.
Good morning or good evening. My name is Catherine. I'm a registered nurse, and I had the pleasure of going to Tanzania last year. It was a fantastic trip, and I can't wait to see what we have planned for 2022.
We have plenty for you to do. Yes. Ms. Kisa?
Could you hear me?
Yes, we can. Thank you.
Okay. Hello, everyone. My name is Qhsc Mokalinga, registered nurse in the cardiac care unit, but also informatics. I'm a member of QHS, and then I'm looking forward to work with you all. I couldn't make the trip last year. Hopefully this year I'll be able to, but I'm so grateful and happy to meet you all. And thank you for everything you do for Tanzania. Hope to see you soon.
Thank you, Ms. Kisa.
Thank you.
Oh, hi.
Hi. Can you hear me now?
Yes, we can.
My name is Bashir Mari. I am an anesthetist and a sonographer at the Buguruni Health Centers. I hear about your trip last year, but I didn't get a chance to be present there. She was coming. Dr. Dina Komakoma was present after me, but I'm very happy for your program, and I make sure I will participate in next program. Thank you for everything you're doing in Tanzania. You're most welcome.
No, thank you. We're excited to come and see you. So what is your first name?
Bashir.
Bashir, okay.
Yeah, Bashir. Bashir Mari.
Mari, okay.
Hello, Dr. Harriet.
Hey, how are you?
I'm fine.
Oh, that's Dina. Okay, go ahead.
Yes, I'm Dina here with Miss Mbilinyi,
Okay.
sponsor. And
Okay.
also introduce you, Mr. Bashiri. I saw
Yes.
there, yeah.
That's good.
Okay. But unfortunately, we choose the place, but I see it's not conducive. But I see.
No, if you can hear us and we
Hello?
can hear you, that would be great. Yes, that's fine.
Yes, I hear you.
Okay, perfect. Okay, so I know we and I believe we met everybody, right? Who am I missing? I think everybody got to be. Okay, so according to our list here, we start discussing about the theater operations and discussion. So I know Dr. Benela from Mwananyamala Hospital is not here yet, but we're just gonna go through that part and then go to the NICU. So the idea is Dr. Gwen Randall is an expert in that area, and she has worked with volunteering to different parts of the world, doing programs about operating procedures, preparations for the OR, and training staff, and then make sure they're providing adequate and effective medication, and of course the safety is a priority. So we wanted her to go with us to Tanzania, Qhsc, to be able to share her knowledge and educate the doctors and nurses over there. So Dr. Zaveneri Banera, she is from Mwananyamala Hospital, and she's the medical officer in charge. And she wanted, she identified the area for operating room as a need and a priority for their hospital. And then so I wish she was here, but there was more. I did share the questions with Dr. Gwen before, so at least she has some ideas. The same concern was also shared by Ms. Dina Konkoma from Buguruni Health Center. And then so that's the part which I believe Mr. Bashir is here also, which is the nurse anesthetist, which will be perfect. So we're gonna need people from Buguruni, we're gonna need your help in training. So when Dr. Gwen Randall schedule training or anything like that, we wanna make sure it's on your side also, people are getting that knowledge before we get there. So a few questions before I let Dr. Gwen explain things that she may be able to share her knowledge. So a few things, Mr. Bashir, in Buguruni, what are the areas what tools do you use for education purposes? Do you use like Zoom or WhatsApp or like slides, or how do you do your training there right now? Oh, you're muted.
Okay, thank you. I'm mute.
Yes.
Yeah, can you hear me?
Yes.
The common tools in Buguruni Health Centers, which we are using in sharing of knowledges, is common meeting, the general meeting, a special weekly, maybe once you're performing every session, or some department may conduct the session every weekly. Sometimes maybe monthly, we have conducted Zoom meeting with some of the RH, some leaders. They may perform. We have some Zoom equipment for perform education.
Okay, thank you. So when we have a Zoom meeting, like a monthly schedule, is it a specific time, or we can arrange those times? Because remember also we are thinking of different time zones. And also we have to find where Dr. Gwen Randall is available. So
Yeah.
I'm gonna give her a few minutes to just to give our options, and then we can see if it works with you guys. Go ahead.
Can I continue? In Zoom, by using Zoom meeting, is the common ways which are using or sharing some educations. Maybe if there is some special education or things which they need to share with us, they will suggest that we can use a Zoom meeting. But common daily, weekly once per department. Every department can perform the presentation in the morning reporting. Approximation 1 to 2 hours. It is enough for sharing some ideas for those departments selected.
Okay. Dr. Gwen, do you have any questions for him, logistics wise, for things that you might need to know before we started figuring out the dates? We're going to figure out the dates at that time. I just want to have an idea. So we want to find a commonality for each hospitals, and we think that we can do similar from one hospital to the next.
Right. So I guess I would just like to know how they see me, and using my expertise there, like what things do they think that I can offer them, that maybe with their meetings or particular things they're having issues with or specific training. So I want to help them in the best way that I can based on what their needs are.
Before Mr. Bashir or Dina answer that question, Ms. Dina did send me a list of things that they think is most common, for example, operating surgeries, so there are general surgery, laparotomy, abdominal surgery, C-section, of course, gynecological surgeries, and ENT surgeries. And majority of the people think, personnel are like 2 general surgeons, 1 orthopedic surgeon, 1 ENT surgeon, 4 gynecologists, and 4 anesthetists. And of course, they don't have anesthesiologists in that area. So spinal anesthesia are the most performed, and then general anesthesia if is needed. Majority of per day, they do 8 to 10 surgeries. So what are the things that you think, Dr. When you can, if they're doing that type of surgeries, things that you can help them with? In general, we have to dig deep and see what else they need, but.
Yeah. Well, if you can send me that list.
Yes, I will.
And I can take a look at it and then kind of go from there. if they're doing a lot of C-sections, then what are the particular issues with the C-sections? You know what I mean? Like if they're
Yes.
using spinal anesthesia, you know, what are their techniques? What are their drugs? You know, how do we do here in the US? Those kind of things. And what are the outcomes, more importantly, you know, with the moms?
Exactly. Do you have anything, Mr. Bashir, to add there? Or Ms. Dina or Ms. Mbilini for surgical staff?
For surgical staff, may I talk something? In Buguruni Health Centers, we are commonly based on obstetric and gynecological surgeries for now, but we have a plan to perform more surgeries for days coming. But for nowadays, we are concentrating on obstetric and gynecological surgery. And as you say already, we don't have anesthesiologists, so anesthetists are common perform some procedures, and spinal anesthesia is just common technical performed. For general anesthesia, sometimes in some emergencies, we can perform. But good in all, sometimes we have any communication or partnership or team workers with the RRH hospitals, specialists. If something may need the specialty cares and the management, we can call specialist, anesthesiologist, and the obstetrician may come for helping each other. So this is why we are working.
So who does the spinals? If you don't have anesthesiologists, who does the spinals for the patients, for your cases?
Yeah, for Buguruni Health Centers, for currently we have 4 anesthetists. For 3 of them are studying certificates, but they have some knowledges, extra knowledge like a clinician and some nurse anesthetist. And one of them are trained 6 months refreshing course, but we are getting experience on performing spine. So both of us will perform spine anesthesias.
Okay. And who does that training that they do for the 6 months? And how much on hands do they get with that? I mean, how is that evaluated? How is their training evaluated?
Our training that you are receiving?
Mm-hmm.
Yeah, commonly we have a partnership with the, we have to thank some CCBRT hospital, national hospitals. They are very cooperative with us. Several times they come refreshing us and some reminding us and cooperate with us and asking if we have a problem. So some knowledge that we need, some problem we have, we need a solution. They can advise us anymore. So CCBRT hospital are common big partnership for us for nowadays.
Right. Do they have policies and procedures that are already been developed?
Yep.
I didn't hear you. So what do you say, Bashir?
I didn't hear very well.
Oh no, she was asking if at the hospital, do you have policy and procedures?
Yeah, we have it. We have it.
Okay. I was going to add, Dr. Mrema, because he's a surgeon also in Muhimbili. Do you see any area that Dr. Gwen Randall could be of help in surgical part?
Oh, she's a surgeon?
No, anesthesia. Sorry.
Anesthesia.
Yes.
What does she want to know about Muhimbili?
No. I'm just saying because we were talking about with Buguruni and how the anesthesia program and how do they take care of the patient. I was just asking, since you're the surgeon and you work with anesthesiologist group in your area at Muhimbili, do you see if Dr. Gwen Randall could offer her expertise or can be of help with you guys with training or education or something?
Oh, definitely yes. Definitely yes. We always receive experts from outside the country, and of course she'll be of help. And they normally receive these experts and they work along together to improve their knowledge and share some experience between the hospitals. And some, of course, you're coming from US. I'm sure that the expertise is the experience is much higher and the expertise is higher. So there is always something to share.
Okay.
and to learn from, yes.
Okay, the reason I ask is because I want to make sure if you guys were set in Muhimbili, then we can get Dr. Gwen Randall focus on Buguruni and Mwananyamala. But if you guys also think she'll be of help, then we can, when we put our schedule, I can make sure at least a few days also comes to Muhimbili, and then we'll plan ahead to make sure we identify areas that you think she'll be helpful, then she can plan ahead from that. And that's the reason. So for now,
yes,
what
sure.
I'm thinking is 3 areas, yes. I'm sorry, go
yes,
ahead.
and we will connect you, Dr. Randall, with anesthesiologist at Muhimbili, so they can identify areas which when she comes, at least she can focus on, and yeah, yes, and I'll connect you with one of the head of department of anesthesiology at Muhimbili, so they can share.
No, that would be perfect. Thank you very much. That would be helpful. But
I
I
was
want to make sure.
Dr. Mkoni was on the line here. I don't know if she disappeared, but she was just on.
Yeah, she's coming. She said she had some issue with the connectivity. She's going to come back because she's going to be doing the next thing also. Yeah, so we wanted to make sure. So if we're going to utilize Dr. Gwen Randall's expertise in the 3 hospitals, that would be great. Knowing ahead of time area that she can focus versus coming and just share general knowledge, sometimes it's not helpful. But if we can identify specifically things that you really need, so she can use her times and expertise wisely and be impactful for those areas. So we appreciate the connection, and then we can get those areas that you guys will identify, so we can give it to her. And Dr. Gwen, I'm going to send you the list from Ms. Dina Komakoma to you. And I did send you the Dr. Benera's list, but I'm going to resend again all the connection, all the lists, so you have things that, and then you can identify, and then probably the follow-up meeting is going to be now individual departments, so we can, I can address even deeper areas like those policies, and so we know for sure we can address versus in general planning meeting. So thank you guys for sharing that part. Okay, so the next thing is NICU and OB. So as I said, we have so many things discussing about the NICU, starting from the last visit when we went to Tanzania. There was a lot of training that we needed to do, neonatal resuscitation, infection, PALS training, CPAP training, and all of those emergencies responses. So I am going to skip down because Miss Nori also, as I said, is the nurse practitioner, and she was going to help out with neonatal resuscitation. So I'll just give you a background for that area, and then if Dr. Mkoni shows up, that would be great. If Dr. Msamichaka shows up, that would be great. They both running around. Dr. Msamichaka is at the hospital working, so she said she was going to come and see us between rounds. But anyway, so the neonatal resuscitation was, here in the United States, we do training. Every 2 years, you have to renew how to take care of the baby at the time of the delivery. And then, so there's a lot of involvement with the OB part, pregnant patients, to make sure we prepare that baby. And then there's a lot of also for the NICU nurses or neonatal intensive care units to be able to receive those babies who are preterm or any complications. So when we did some training when we went to Dodoma, but also when we went to Dar es Salaam, we visited the NICU at the Muhimbili, and Miss Catherine Dudek and Miss Victoria was there, and Miss Valentine's was there. And there was a lot of things that we could do to help with infections, like with the thermoregulation, phototherapy, and the list goes on. And I know Miss Catherine took a good notes, and I'm sure she still have those notes. So those are the areas that we were trying to focus on this mission. And then so we also wanted to know how many babies Muhimbili has, and of course Buguruni also. We get the same training for the OB nurses and the NICU nurses or postpartum nurses to take care of those babies. And then of course for the Mwananyamala also, it'll be exactly the same thing. And then another big area there is postpartum hemorrhage. So of course we know all these complications for the moms have, and then when they come and deliver, and then once they deliver, their mom gets sick. So we have to do again those training for postpartum hemorrhage. So I am gonna let Miss Inori just say a little bit about the NICU and things that she may be able to do. And then just to preface your response, Missy, we are planning to do some training before we get there. So let's say usually we see, we provide maybe training every other month before we get there. And then when we get there, almost we do like a mock drill to see whatever they've been training throughout the time, they can perform those skills that we want. So I was hoping if you can let us know if you'll be available to do those like either monthly or every other month training for the neonatal resuscitation. And then if we're able to do those things, how do we think logistically, how can we try to teach them? And then if there's something that we need to figure out from Tanzanian side, then we need to address them.
Okay, yeah. So I think there are things that would be easy to kind of start with. And I recognize actually we do have a new version of neonatal resuscitation. It's the 8th version. It kind of takes and divides people who are more likely to be actively involved in a resuscitation and those in which who may be the first responders, but not necessarily continue the resuscitation with all the skills that are needed. So I think we could talk a little bit about how we want to see this for your folks and who, or even if we should divide it that way, if we should leave it together or if we should continue and having it separated out between the two groups. So that edition just came out October of last year, with this year being January 1 being in the United States, everybody has to be on to the 8th edition. And yeah, I would be happy to do simulated events. I guess I have to think about how to make, I think probably just through a Zoom meeting, just like we're doing right now, would probably not be difficult to do. I have low fidelity and high fidelity simulators that we can kind of get started with, but maybe we can start out with some of the low fidelity simulators and just kind of talk about like more of the first person who's in the delivery, who comes upon a baby that needs help.
Okay, excellent. So another thing is, so because they don't have those NRP books, neonatal resuscitation books, they don't have them. So do you think it's possible to have all those like different sections? Let's say if you're doing monthly 1 hour, do you think it would be possible for you to be able to train them, provide those training for those 3 hospitals, and then have them master that skill for that month, and then accumulating until by the time we go to the medical mission, they have the whole, like course, and then you'll be able to do like those little mock drills when we were there, just to make sure they got it. And
Sure. Let me turn my volume up. Can you hear me, Harriet?
Yes.
Sorry. Yeah, I think that we could do that. Even sending just maybe 4 books or something to each institution, or 5 books, something that they could have and they could copy and review. Although the only unfortunate thing is I don't know what languages they're translated into, and it probably would be easier. I have to think about this. But certainly we could.
The books can be in English, which is fine. They can use the same books.
Okay.
Mm-hmm.
Okay. Yeah, so I think that would be okay. So you're thinking, okay, so this is February. So you're thinking maybe March, June, like every other month or every.
So we see how many logistically from their side, we see how many employees or staff can be released to go for the training. If the number is too small, then it means the frequency is going to increase like every month. But if let's say 1 class is the maximum number you want on a 6, do you want 12? So to see on the other side, how many can they bring them? to make sure they practice or learn, or in the beginning, we can have up to 40 or 50, you know what I mean?
Sure, sure.
So those are the logistics. I mean, we're gonna do outside this meeting, but I just wanna make sure we can get their feedback also from them.
Okay. I also have a nurse practitioner at Miami Valley who's a neonatal nurse practitioner who's also interested.
Okay.
So Lisa and I could team, and if it needs to be every month, then maybe, you know, I could do it every other month, and then she could do it on my off month too.
Oh, that's even better. And I know I think Buguni and Mwananyamala did request intubation for the neonatal intubations. So they requested that part also, and I believe Dr. Gwen also is going to be able to do that, the intubation part, right?
Yeah, I mean, sort of when there's a crash like that, anesthesia is always involved anyway. So, you know.
Yeah, I can even bring some an intubation head that we use. And I can actually even, I think I'll ask Ruby if she'll let me bring the premature Annie, who's really tiny. I mean, she's not really tiny, but she's small, and I think it would be a good simulator to practice with.
Yeah, so that also definitely that's going to include the anesthetist and people in the operating room. Almost that's going to require everybody for those 3 hospitals. As I said, we're going to work out on logistics to see how many the number of the people who needs those training, and then space them out. And if you have the second person also, Miss Missy and Dr. Gwen, if it is intubation time for that neonatal training, then yes, we can tag team to make sure we address that as much as we can. And for them to be able to do return demonstration, so at least we can see from far away. And then when you go for the medical mission, it's going to be an actual mock drills, so we see actual skills are performed and hopefully continue to save lives.
Sure. I also have a CMAC that we can do some simulated events too. It's actually a really nice piece of equipment that you can see that's quite large. Well, you'll actually see the procedure itself. Like, I know people know how to do it, but sometimes looking at these landmarks. In addition, I do have videos from past intubations that we have used, and we've retained those under the auspices of education in our facility. So I'll pull some of those because I think it's really nice to be able to see an actual airway and not a plastic doll. So I'll run through a couple of those to see if I can find ones that would be particularly helpful.
Oh, that would be perfect. Thank you. Dr. Msambichaka?
Hi, I'm sorry I came late, so I missed the part. I just wanted to ask for clarification in terms of, I think you're talking about neonatal resuscitation. Are we talking teaching them NRP or talking like helping babies breathe?
So for the healthcare and individual at the hospital, we were talking about the NRP. If we are able to do, almost they could end up having a whole course, like not exactly to get the certification for the NRP, but just all the process through it. So if we do every month training, so big chunk of it, so at least they get the most of it. But if we were only doing one day, definitely it's going to be help baby to breathe, because more like you're not going to teach all these technique things in one day.
Okay, the one thing I wanted us to consider is reaching out to them and seeing what their current protocol is. And I'm just talking based on my experience with trying to teach NRP in Rwanda. One of the challenges that I ran into was just the way the delivery room is set up. You know, here you have dedicated baby nurse, and then, you know, other circulator and, the other nurse just in charge of mom. And what I recognized was there was really no dedicated like baby nurse. And then the equipment that they currently have might not support NRP. We might have to modify it a little bit. So just trying to figure out what their current process is. That way we can modify what we're teaching them from an NRP standpoint to meet the resources that are on the ground, because it might not be completely applicable.
Perfect. That's an excellent point. Thank you, Dr. Msambichaka. Mr. Bashiri? I'm gonna get you to speak. And so she was asking about the delivery room where the babies are born to, like, how do you receive that baby? Is there a nurse or somebody specifically for that baby? And what training do you get to for resuscitation? What, did I lose him? He disappeared. Ms. Mbilini, can you answer that?
Yes.
Yes.
We always, in the theater, we should have the nurses who are ready for receiving baby, who are training for resuscitation for the newborn. Therefore, immediately after birth, it means their doctors, anesthetists, and their nurse, theater nurse, they are there with all the resuscitation tools in place to receive the baby and make sure that the baby is okay. After a few minutes, after assessment, then they should be sent to the wards. So they're all there as a team, helping each other to make sure that the child is okay immediately after birth. And they all facilities needed for resuscitation. Yeah, the nurse make sure that they are there and
did I turn it off?
Go ahead.
Yeah. Yeah, that's all.
Okay, so Ms. Mbilini, do you have specific training for receiving or resuscitating the baby? Either the nurses who are coming to receive the baby, do they have specific training, like either maybe every 2 years, every 3 years, or?
It depends, but the nurse, she must be trained. Even myself, I've been trained before. Okay. And sometimes we used to share in a CME, continuous medical education, if there is any updates on resuscitation or any new technique on resuscitating the baby. And we share in the meeting, we share in the ECHO meetings with the other hospitals, example, Mwimbili and the other referral hospitals, if there is any new technique of doing resuscitation to the newborn. So before you attend to a theater or you deal with the theater, you should be trained.
Okay.
Yes.
Dr. Misamcheka, you had the response, right?
Yes, I did. Thank you very much. That's very helpful. Ms. Mbilini, are you able to send us, like, if it exists, like the current, protocol for the nurses, like, if the baby is not breathing, you do XYZ, then, within this many minutes, you do XYZ. Like, is there something like that exists? If not, then obviously NRP will address that, but it would be helpful to know what you already have so that as everybody is, putting together the classes, we can at least know what's already available and compare it to what we have. But thank you, that answered my question.
I do because also there are some SOPs which lead a nurse to do this and this systematical and what is required to a baby according to his or her condition. So I do.
Yeah, so that will definitely help.
Yeah,
like
we need also to get support, more support from different missions, as I think what you are performing will be very, 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 it will be very necessary to us to get any new technology or any new techniques and how to take care of those new neonatals. So we are on need, although we are doing, but we are still on need to be supported.
Yes, we agree, Ms. Mbilini. That's the reason that we are here, because as what Dr. Msambichaka just said, if we know what you guys do right now, then we can see what we can support or facilitate or provide to emphasize or potentiate the care of babies. Yeah. So no, definitely, yeah. So we want to know, because we don't want to start from scratch and maybe half of the things you guys have already done. We just want to know what you're doing now.
Yes.
And then so either we can supplement or try to help from there and build it up. So to make it more efficient.
Yes, yes, yeah. That's very good because we need it always every day to improve the quality of care every day.
Yes.
Because, you know,
Go ahead.
things is changing day by day. So it's very important to improve our services. So I think it's a good idea.
No, we appreciate you even raising that point because that's the reason every expert here is here for, because we want to improve that care. We want to try to see whatever we know we can share and improve that care. And the goal is to ensure patient safety, or including those little babies. So definitely. Do you also work on the mom side?
Yes.
Like on the labor and delivery also?
Yeah, we are working. Yeah, I'm working. The delivery and the labor.
What about the postpartum hemorrhage? You guys have specific training, or is just whatever you learn from the taking care of the baby or on maternity class? That's it. Do you have like drills or something like that for the postpartum hemorrhage?
Yes, we are taking the care of postpartum hemorrhages, even antepartum, all of the above this. We are providing services, we're managing such plans. So we also need support to get updates to improve the management. Yes.
Okay, and Dr. Benela's from Monanyemara. Unfortunately, she was supposed to be here, but unfortunately she's not. But she did raise from Monanyemara standpoint that they do need a postpartum hemorrhage training for the nurses and doctors there, and also addressing those issues. And also one of the other factor that I asked, do you screen patients for diabetes? So when they're pregnant. And then so those are the part that she also raised in addressing postpartum hemorrhage. She also raised that they needed to learn about the diabetic and the hypoglycemic protocols. And so there's so many things that we can add in there to make sure we address both sides, from maternal side and newborn side. And in your hospital, do you guys do hypoglycemic protocols?
Yeah, we are doing, because we follow those protocols to manage the pregnant women at the labor, at the antenatal clinics, even after deliveries, to make sure that we manage and we monitor the maternal and the fetal progress. But I think for your planning and your support, and if you will come, I will see the gaps we have, then I think you'll give more support, but we have them.
Okay.
And we continue to manage accordingly, but I think your presence and your mission will help us to improve more, to give the better management and improvement, both for the child and the mother.
Okay, so that'll be great. So if you do have hypoglycemic protocol also, including those neonatal resuscitation, I think that would be great. So the neonatal team can know where you start with, and then so we can build on it. So to make sure we support you where you need the support the most. So if you get a chance to have those information, send it to me, and then I will share with Ms. Inori and Dr. Msambichaka. Dr. Mkonyi also, she was here, but I don't know. She said she has issues with the network, the phone, but she's traveling. She's not at home. So if we share those information, that will help us so we can prepare effective training. Yes, Mr. Bashir.
Hello. I'm sorry. Network was a little bit disturbing, so I'm ready to set it. Have a chance to talk something?
What did you say?
Network was a little bit problem, so I'm ready to solve it. So I have a chance to talk something about.
Yeah, you can speak if you have something to say. Yeah.
Yeah, I was just want to say a little bit about the neonatal resuscitation. You was asked me what I'm thinking. Can we help in helping the baby breathe in theaters or operating room? I think now I'm thinking that help baby breathe or HBB is very important knowledge to everyone who working antenatal, postnatal, and neonatal, especially in the theaters. because most of operating emergencies clients they should present with newborn babies problem. So if everyone having some knowledge of helping those babies, it will be helpful to save a life of those babies. So my thoughts is everyone should be receive these knowledges, even though the time will be limited, but we can't get the knowledge all of us at once. So schedule the time and giving some feedback for each other will be the nice way to cooperate each other on this knowledge. Thank you.
Excellent, Mr. Bashir. Yes, that's why we don't want to just wait until September to come and give that education, We want to do at least monthly, even way before we get there. At least you learn the background and what the techniques are we need to be able to employ, the SOPs to make sure standard of care also has been addressed. By the time we get there, it's going to probably be like a validation or mark drills to see which roles the people are doing, and then how do we did we gain anything from all this education to make sure we improve the care. So yes, we do want to do in the long term, not this is just a quick bandage fix on one day. So I appreciate that acknowledging that, because we're going to need your help. So when we schedule those meetings or training, when those global experts are sharing their time and expertise, so we want to make sure also on our side in Tanzania also, you guys help us to bring the individuals or the members who need to learn those skills and make sure make that time worthwhile for both people. So thank you.
Thank you, sir.
Okay, so we're gonna jump into the pediatric, and then which is gonna include for the eye exams and health screening, and also gonna finish up with the band. So for the pediatric screening, the I put is almost like twofold. So one of them is screening, because this is like health, the athletes, we're trying to see if they're healthy enough to practice or play their sports. And we know if you work with pediatric population, they always want to hide their injury so they can continue playing. So Ms. Catherine, we tested for that, because when she was teaching during the medical mission about prevention of minor injuries when you're doing the exercise, the little kids, after she finished presenting, they are coming and say, oh, I hit my legs here, they need the ice pack. So, but anyway, so we want to make sure we address these kids and identify, give them tools to identify if they're hurt, then to address that part. So that's one side. But the second side is to do, we did the height, weight, and to try and find the BMIs and all the stuff. So Dr. Mstabichaka was involved last time, but not necessarily physically, but when we came back, we shared the information from there. So we want to be able to see if we can address even from far away before we get there. What are the things that they need to do, if they need to measure their weights and heights, and how do we need to do? By the time we get there, we address the children who needs further screening. But the other part also is nutrition, because the children are growing, so they need to eat healthy. So another nutrition, we were able to discuss type of food they need to eat, the food pyramids or my plates, all those stuff will be included in this training. And those are like any volunteers who is going to work with the nurses and doctors to be able to teach these kids will be helpful. We have almost more than 300 for the athletes, and then we have almost 800 from one of the school children. So addressing those two areas is going to be a big task. So we're going to need the help from everybody who is involved in those areas. So the pediatric screening also depends if we get Dr. Mstabichaka and the other pediatricians, if she can recruit like 10 of them. So then we'll be able to do the screening for this physical screening for these kids who we all know probably they've never had any physical exam as a pediatric person. So if we can get that, it's a huge thing, but if we can get that, then that would be a great thing, because at least we can identify the children who are at risk, and then try hopefully to offer the support that they need to go and get checked out. Speaking of the children who are at risk, then we have the children who have vision issues. We know that if the kids, they may not know that they have vision issues. So they go to school, they can't study, they can't do their homework, they can't do, and then of course we are quick to judge them and say, oh, this is lazy or doesn't want to do it, but the child cannot see, and they don't know that they cannot see. So thank God to Dr. Vanessa Semville. So when she goes there, she'll be able to go to one of the school, Mnazini. They've already identified the children that who needs who needs vision screening because of their they have problems already now. So hopefully she will go and help them and see if they need glasses. Then yes, if they need more than that, then we'll probably follow up with other physicians in Tanzania. So for the Dr. Vanessa, so we do have, I'm going to give you a little background. We have 800 kids, and we have, and they are divided in each grade. So each grade almost like close to 100 kids, and then they've already identified the children who really need the vision screening. They're like almost 35, and then the children who are at risk for other things, mental health, asthma, cardiac, and then the other one, they said they don't know, but the children is sick all the time. So that's why I was hoping Dr. Msambi Chaka and the pediatricians who, if we get more of them, then we'll be able to do some screening for these children, at least to know who is at risk. So going back to Dr. Vanessa, for the kids who need the vision screening, so we will see how many days we can go at school and you'll be able to perform those screening. And also we'll see, also we're working with Muimbili, the vision department, to see if you can go to the clinic there where you can see all the adults and children who are going over there, and you can go and work with them just to see what you can offer your expertise on for what they're doing there, and then we take it from there. We are still working with Dr. Selina Muhina, and she's gonna give me another contact person who you're gonna be working closely with before we go there, so at least you know what equipments you may need to take to Tanzania, and then what are the things that, just in case if you identify the child needs more than what we can offer that time, who should they follow up with? Because we don't want to identify, okay, this person has, the child has issues, and then we don't know where to refer them, so that's not fair. Yes, so I mean, it's something like that. Unfortunately, Dr. Selina was not here, and she could have given us more information, but we work with her afterwards. So what are the things that you think, Dr. Vanessa, you may need or want to have for those screening for the kids?
Okay, so the what was the number?
35, that's the one that they identified.
Okay. So for the kids, I should not, because the primary focus is to see if they need glasses and to give them the glasses. It's two things when it comes to screening. And we do need to have a follow-up. But mainly, you know, normally, as I said, I've done mission trips in the past, and mainly it was just the people just wanted the glasses. So we just did refractions. And so that way we saw a larger amount of people. But if you want the main focus to be health, we will see a lot less people, and then we would be able to coordinate if there's a problem. We, you know, having an ophthalmologist who can do surgery and other things. So we just need to I kind of need to know what is the focus. Are we just doing glasses, or it's a combination of both? And then, you know, one big help, which is something that the other group that I've worked with didn't do, was what you're doing, actually identifying those who need. Usually there's, in the other missions that go on, there's a line in the morning. I mean, people are waiting in line the night before you get there. There's like 500 people sitting there waiting for you to see them, which is impossible to see all those people in one day. So this is a great thing in that we're seeing those who need, so we don't have to kind of scour through and find out, you know, because this, once you do a mission, everyone wants something, and they think, you know, even though they don't need glasses, they used to beg, just give me something, and we say, you don't need it, you know. So at least we're not wasting time. And that I felt very frustrated with the other missions, because there were so many who were online who didn't need, and then there are like old people who needed something and couldn't get seen. you know, or children who was on a long line that couldn't get seen. So this is really good that we're identifying. And I think even with the clinic too, if we can keep that up, because if we can, then it's not only the medical, the glasses, but then I can do a little bit medical. The beauty of what I do is that I have a lot of my equipment portable. I actually, and I was actually looking into another piece of equipment, but you know, I have the ophthalmoscope, so I can see in the back of the eye. I have a tonometry, so I can measure the eye pressure. So a lot of the things, because I've been doing this many years, I've gotten portable equipment. I mean, obviously, if we're going to the clinic and they do have, you know, the regular instrumentation, that'd be great. But it's not a deterrent, because I do have a lot of the equipment to you know, portable slit lamps, so I can see if they have cataracts. I do, as I said, the tonometry, I can check for glaucoma. I can look in the back of the eye, so if they're diabetic, I can see if they have diabetic retinopathy or hypertensive retinopathy. So I can do that. I mean, it's just, and because of you guys, you know, cutting down and kind of pulling to the side those who don't need the services, then I can spend more time on those who actually really need the services. So that'd be great. And definitely having the backup ophthalmologist and surgeons that we can refer them to would be greatly appreciated. So we're just not leaving them without, you know, follow-up.
Yes, I agree. Mr. Siakabe, you wanted to say something?
Yes, I have a question for Dr. Vanessa. So when you had those long lines, what would you say was, just an estimate, was the percentage of people who needed versus the percentage of people who didn't need? Not the ones who just wanted, but
right. The problem is, let me see what would be the percentage. I would say probably about half that really didn't need. You know, you come into, you know, as you know, I've done many times in Dominican Republic. And as you know, and we would go into the bate. So once our van comes, you know, everybody's in the mindset they need something, they want something, you know. And so because of the younger ones or those who, you know, they supersede, or they whatever they do, and poor kids and the old people are left, you know, back, and you can't see them. So I would say about half, you know, they just want something. And it wasted so much time, and you felt bad, you know, for those who you knew needed, you know. So I love what you're doing in that you're identifying. If we can do that with the clinic, identify those who just have the problem, because they just felt like, oh, you're giving out glasses, I just want it. And I'm like, you can't see, you know. I had to stand up there and show, look, you put it on, you can't see with it, like looking at, you know, but they still wanted it, you know, that kind of thing. So if we can weed that out, then I can spend more time doing the ocular disease part, looking to see, is there anything else going on? The other missions, it was just refractions, you know, just getting them in, seeing what glasses they need and out. And I didn't get a chance to see if there's any ocular disease.
And then you mentioned before shipping a piece of equipment. Is that the equipment that you're talking about?
No, I'm not. I decided that I'm probably not going to take that piece of equipment. I'm going to take the smaller, more portable ones with me, because the glasses, the container for the glass is going to be, you know, it's big. You know, I have a place that donates a lot of glasses for me, and that's big and heavy enough. And I have to, you know, it has to come with us. So, yeah, I'm not gonna add. I'm just gonna bring my own portable. So if I could see what the clinic have, would be good. But I'm gonna bring my portable equipment. The only thing is, you know, it's portable, it's smaller. It sometimes take more time than say the big ones that's in the office. So if I can use some from the clinic, fine. If I not, I still will have my portable one. But no, I'm not gonna bring that piece of equipment.
Okay, that's good, because we were trying to figure out we were trying to figure out a shipping date, because we were assuming that this would have to go by a sea container or something. Or
yeah, no, I'm not gonna. I'm gonna take all mine with me, and you know, with my backpack and stuff like that. So yeah,
Nice.
that would be good to bring that one, but it's just not, it's not going to be feasible. And yeah.
Dr. Vanessa, I have a question.
Sure.
Will you accept any prescription donation? It doesn't matter, and you can sort it out when you get there. Because I know a lot of people are looking for a place to donate glasses, but they're varying prescriptions. They're not just cheaters. You know, one eye could be stronger. So is that something that you would like to accept as a donation?
Glasses, yeah. Yeah. I mean, when I started, that's what we started on, donated glasses. I would like if there's donated glasses for them to give me ahead of time, because I don't want to spend the time to try to because what I have to do when I'm given the donated glasses, I have to neutralize the prescription. I have to see what prescription it is. I have to label it so that when I have a patient that needs that particular prescription, it's already labeled. If I was to spend the time, usually how it would work is that people would donate glasses. I take a full year, because it's not how much glasses people donate, to actually neutralize it, mark it, put them where, when I'm in a clinic, make it like a dispensary, so that, you know, all the pluses, all the minus, all the stigmatisms, all the, you know, progressives, all the bifocals, they're all in a bag where, you know, we just plump them there and I can reach it quick when I need it. So if there's any donated glasses, I would need it ahead of time so I can do all of that and just bring it and be ready to, you know, to be able to give it out, and not, because it takes time to neutralize the glasses and to get it. I like to clean it up, put alcohol in it, clean it up, and do all that before giving it out to the patient. So it's work. And usually it would take me a full year to do all of that, because I'm working, I'm taking care of my mom, all kinds of, so it takes time. Yeah. So if I could get donated glasses, I would need it as soon as possible to start working on it.
And she is in Florida.
Yeah.
Great. Okay. Never mind. Okay, so I'll see if they can either come neutralized and have it ready to go, or if I can get that to you as soon as possible.
Yes, you can get it to me as soon as possible, and I will get going on it. In fact, I have to, because I moved from New York to Florida, and I had everything in storage. I have a lot already, but, you know, obviously you can always use. So I try to, you know, pick out the best of it. Always tell people who are donating glasses, no broken glasses, because people, you know, they like to send glasses, oh, it's broken, I cannot use it, I cannot fix them. I don't have the time or the energy to, even if the screw is missing, it takes too much time to try to find screws and temples. So if it's broken in any way, even the nose piece is missing, don't donate it, because I can't use that. Yeah. And I can't tell you how many times they donate broken glasses. If you can't use it, then no other person can use it. That's my philosophy, you know.
Dr. Samichaka, do you want to say something?
Yeah, this is great stuff. I'm very excited. I have a couple questions, one for Dr. Harriet and one for Dr. Vanessa. Dr. Vanessa, I'm very excited to actually work with you and see your work. Dr. Harriet, do we know, I think the focus for this mission was kids, right? It was pediatric screening, right? Or vision screening, or is it encompassing adults as well? That's my first question to you. And then the other question is, the ones that have already been screened, I think you said 35, who's doing the screening, and is there potential to screen more people? Or is there potential for, like, when we get there, if it's a school, for us to do, like, you know, the basic vision screening and then, you know, identify them and refer them to Dr. Vanessa, so that we, you know, similar to how here, if especially I'm thinking children, how we would go to the pediatrician's office, you know, they get screened, and then we then utilize Dr. Vanessa for the, you know, screening more for like the eye disease component.
So two things. Thanks for your question, because I was just waiting for everybody to speak, and then I'm going to come and address that. So yeah, so initially we wanted to do like screening for everyone. In the school that we were going for, you had 5,000 kids. And then we find out that logistically it was impossible for us to go there, and we didn't want to just do one grade. So we went to the closer school, which is Munazi Moja School, which has 800 kids. And then so we wanted to make sure, because if it was only Dr. Vanessa, she's not going to be able to see all 800 kids at that time. So, and we discussed it before, we said, okay, can we identify the kids that who needs? And the people who did the screening are the teachers who already identified the kids from the beginning that they cannot read, they cannot do this, and they're struggling, and they don't have money. And whoever is screening them is just a teacher to see that. They have never gone to the eye data. And she said some of them back home, they don't believe that somebody's going to look at your eyes and fix it, and whatever other reason is. So the teachers are only ones who will identify. This is like written in the class. They know for sure this child cannot see maybe, and then they have issues with the vision. So then either they're giving accommodation because of that. So the people who did this screening is the teachers. So my concern with that part was the same thing that you are asking right now. Is like, so we identified the 35 people, and then Dr. Vanessa will be able to screen even further medically to make sure what they have or what they don't have. And then so if they need further treatments, then definitely we want to make sure they might get it if we can facilitate that part, yes. But my concern is because the other quick math, 765, nobody ever did the eye exam on them or even vision. So if we have enough people, can we just do, like that smelling, reading, and see if they can? Or should we just focus on those 35, make sure those are identified and get the best care possible from Dr. Vanessa? So that was going to be my other options. And if we can address or recruit more people, thank God if we have like maybe 2 or 3 Dr. Vanessa's colleagues, then it'll be even perfect, because either she can focus on that and then the other ones can screen the whole rest of the school. Or can we just do basics vision screening for the whole school and see who we can get out of there? Because some of them, yes, they might have issues, but they've not been identified. Or some of them are like in that little cutoff. They can't see far, they can't see close, but they don't know what to say, and then they can be labeled that they're not intelligent, or they cannot read, or they cannot focus. And then so just be left out there. And if nobody identify them that they need help, then they're left on the on that group. So that is the part which I'm glad you raised, Dr. Msambichaka, but yeah, that's the part which I was thinking, like, if we are able to get more people, then yes, Dr. Vanessa is going to start with those people who definitely need, because we want them to get the need and address it and hopefully get the treatment. And then if the rest of us, we can do basic things, then yes, let's just screen them and see whoever is in there. And if we identify some people who was at risk, and Dr. Vanessa is done with those 35, then yes, we can get her expertise before we leave out of there.
And I have another question real quick. Vanessa, your portable equipment, is it battery powered and electrical, or is it just electrical, or?
It's battery powered. Some are electrical. Some are electrical, but you know, they have the rechargeable batteries and stuff like that. So normally, because we've been to some places that really had no electricity, so I was able, like back at the hotel, recharge them overnight. And you know, I mean, there were 1 or 2 times that they died and just couldn't do anything more. But for the most part, if it's like a school, I'm sure they have electricity. We can just plug it into, hopefully, right? Yeah, I know.
We might find an outlet somewhere.
Yes, we might find an outlet.
It couldn't be any worse than the Bate in Dominican Republic, because when the sun went down, there was no electricity, nothing. So when the sun started going down, we just had to leave. Like, I don't mind working till 8, 9 o'clock, but you know, it was dark. So we had no electricity there. And, you know, coming down to the end of the day, everything died. So, you know,
can we have extra batteries?
That's a couple of my instruments. I do have extra batteries.
Okay.
So,
like extra batteries.
What another thing that we can do, as I said, that I would need a team. Now, when I did my other missions, I had a team, and that was 4, maybe 5 people, and that's what they did. They did acuities. They put the chart up, and they had the kids, you know, read, and that's what we started doing after a while, because we just didn't want those who really had problems to be ignored. So if we could get, and we used to put them on another side, so they didn't know I was even there. You know, because then you come into the part where they know I'm there, they pretend they can't see, and then we're you know, sometimes it was very frustrating. Yeah, because they want something. So they, oh, I can't see anything. And then I'll get them and they can read the bottom of the chart. So it would have been good if before we even got there, somebody could do, you know, you get a group of people who could do the screenings, you know, before I'm even there, and we have the acuities. That would be the greatest. And then there you would be able to pick up a little bit more because you would see what level on the chart they could read. So I don't know, and taking acuities are very simple. We used to have high school students do that, getting them just to read the chart. That would, I think, would be great. Even in the clinic, just have them read the chart and get their acuities and have that just documented.
I agree with you, Dr. Vanessa. That we are going to have, I mean, you're going to have 4 or 5 people who you're working with, but you're going to have more people who, they're not medical people, but they'll be able to read. Yeah. So for the acuity, we can do that. We can have 3 or 4 people just tag team wherever each class. That's fine. Even if we do it right there, we have more people to do that because there's so many people who wants to go.
Yeah.
So we are going to
So
go
if you can make sure that you have an acuity chart and they're at the proper distance of 20 feet, and just make sure they cover one eye, cover the other eye, read the chart, and then just document, you know, what they read, 2040, 2050. That would actually, we'll probably pick up a lot more kids, obviously, because, you know, the teachers just know these kids have a problem, but we'll actually have numbers and we can get to the other kids. So I'm sure out of 800 kids, there's going to be a, you know, when you said 35, I was like, what? You know, 800 kids, you expect at least 300 to 350 of those kids needing glasses.
And that's what I said, I mean, like, because usually people label somebody who can't read or they get tired of reading because, oh, he's lazy or whatever. And I agree with you, 800, you get only 35. Because I asked her twice, I'm like, 35. She's like, oh yeah, those are the ones we identify. Probably those are the worst case scenario.
They're the real bad ones. Yeah. They're real bad.
There's more than that. And as I said, we can get those team, I mean, we can get people who are not non-medical. We do the real training even before we get that. We have the supplies to fit even each class and they can screen every single child in there.
Right. That's what should be done.
Yes.
Yeah, that actually should be done. I mean, with 800 kids at the time that we have there, basically I should, you know, be there basically the whole time. And I feel that even if we go to the clinic, their acuity should be taken and we should only see. Now, how many days are clinic days and what are you looking at from me?
So that's the part which after I speak to Dr. Serena Mhina, and we're going to figure it out how many days you can go over there and how many days you can stay in school. Because our goal really, we wanted those pediatric children to be able to identify children at risk, to be able to say, okay, these are the people that we need to address. So I would rather you be in the school more than the clinic, because these children, as I said, I can guarantee that they have never seen doctor checking their eyes. So if we can go and screen them and finish them, yes, you're gonna start focusing with the people who really need the most, definitely. And the rest, we identify, like what Dr. Msavichaka just suggested, we identify to try and make sure, okay, if there's somebody is at risk, then we identify ahead of time and see what we can do it. But yeah, so more likely you're gonna have more days in school. Either it's 4 days or 5 days and then 2 days in the clinic, and that's what we figured it out. I have to know how many days they will let us go to the clinic and which days we should go there. And then the rest, we just go back to school.
Okay, yeah, because that is key, because children glasses are the hardest, obviously, to get. So when it comes to children, it has, we're gonna most likely have to do new, because children glasses don't last long enough for you to be able to, somebody to give you or to donate. Kids, they break their glasses, so we don't get donations of children. So that means, that's why it would be, I'd like to know ahead of time what we're looking at. So, you know, because if we have 300 kids, that means you have to bring, to be able to get everybody's prescription, you have to bring at least 3 times the amount of glasses with you, so that we have that person's prescription.
Okay.
So if we're going to mostly be in the schools, then I have my work cut out into getting children's glasses.
Yes.
Yeah. That nobody donates children glasses. They're not in condition to donate.
That's true.
They're broken, you know, or scratched. You know, you can't give it to anybody. So now I have to go around pleading with different organizations to kind of donate, you know, children's glasses.
Okay,
Okay.
that's good. Who is on, is it Dr. Mkonyi? Who is in iPhone for 11? Hello, somebody? Dr. Mkonyi? You're muted.
I just sent them I asked them to unmute, but maybe they stepped away from the phone. And I think Dr. Msambi Chaka's, oh no, she's back. Okay, I thought we had lost her. I wasn't sure. I don't know if she still had another question or something.
I see Dr. Mkonyi was sent me a text here that she said she's at the airport connecting flight. I'm not sure if she wanted to speak or anything else like that. Okay, no, that's fine. Dr. Vanessa, thank you very much. We're gonna continue discussing and try to figure it out. What is gonna be the most impactful, like how many days and how many things do we need? You are going to be the team because, as I said, I have so many people who, not necessarily that the healthcare worker, but they're dedicated ones to do it. So we are going to have people, if they can do acuity screening, that's perfect. We're gonna screen everybody else. And I mean, that makes me feel a little bit better because I was feeling a little bit stressed out just to do only 35. What about the other ones? Because out of 800,
you know, it's a lot more.
Yes, they have to be more than that, but you can't vouch for that because nobody has done the screening. So if we do that, that'll be perfect.
Do you have someone who can show them the proper way to do acuities? Because it's simple, but it's just, you know, the right distance, the right, you know, and just jotting it down.
No, I think we do the acuity when we were there, because we're gonna have so many people who can do that out there.
Okay, okay,
Yes.
so then I would be able to show them the proper way.
Yes,
okay.
Because we're gonna train them before we get to the medical mission, and then once we get there, it's gonna be accurately done. Yes.
Okay.
Okay. Who was in 11?
Do you have any other optometrists or ophthalmologists who's coming with us?
Not from United States. I mean, I have the
from there.
Yeah, from there, but yeah, not here. But when we start recruiting, starting next week, we're gonna start posting individual areas, and then people can focus on those areas and recruit for those specific areas. So then we get more people. Yeah.
Okay.
Right now, because I have so many people who are not specifically for these areas, but they want to come and help. And so we're gonna try to focus on the experts who on those areas. Yeah, so as I said, for you, yeah, we definitely get you more people to do the acute screening, definitely, because they want to. And we have a few nurses who you can work with them when you're taking care of these, those starting with those 35 kids. If you want them specific things to do, then yes.
Okay.
Yeah. Okay, so Dr. Mrema and Ms. Victoria. So we are talking about the burn area, burn care, and it's a little bit exciting that we are looking forward to come back to Muhimbili. I know when Miss Victoria came and she was so happy and she felt at home. We were like trying to get her to leave from Muhimbili that day. She was like, no, wait, I'm working here, I'm working here. I'm like, no, we need to go, the day is over. No, but so she was excited, and then she told us what she saw or observed at Muhimbili and how much things that we can do to contribute and learn together and improve the care or provide resources, the ones that we can. And I appreciate that before, Dr. Mrema, you sent me a list of things that you guys feel like you need for the training on the care for Muhimbili, and we are working on it and try to see what are the things that we may be able to provide, and what are the knowledge that we can share. So I'm gonna let Ms. Victoria start, and then I'm gonna go back to Dr. Mrema. So things that you did, Ms. Victoria, for previous mission, and things that you hope we're gonna do this coming mission. Oh, you are muted.
Thank you again. So on the previous mission, I really didn't get to do a whole lot, but I did get to observe and get a chance to walk around in the clinic area with Dr. Mrema. I did get to see some of the complexities of how shall I say, scarring that the children have gotten. And so I know that there's a deeper underlying need for them to have, you know, a greater care than just living with the scars that they have. So I also got a chance to go into the unit and observe a few of the infants there. And I guess upon observation, I just noticed a variation of differences for what I'm used to working with, whether it was IV poles or, you know, children needing IV treatment or feeding enteral treatment, that kind of thing. I just noticed that there was just a varying difference of what I was used to working with, whether it was the equipment and all that kind of stuff, the supplies you work with. So, have to remember.
Yeah, thank you, Ms. Victoria. Yes, we have a lot of challenges. We have a lot of burn cases, pediatric burns, adult burns. We have, we see a range of post-burn complication, a lot of contractures, and we see also severe burns in children. And unfortunately, we lose some, and some we save. Our unit, we have the SOPs of treating the acute burns, as many areas do, and we are doing our best in acute burn care, but it's not the best, but we are trying to do some the best we can, depending on the facilities that are available to us.
Mm-hmm.
And we do a lot of burn reconstruction, skin grafts, and contracture release after, if we have some complications afterwards. We face a lot of challenges in nutrition. We don't have this parenteral feedings and all that. So we only depend on food from home. That is, it depends the start of the financial start of the parent, that child. So if she has some difficulties in financial status, then you don't get enough nutrition for that child or for that patient. So nutrition-wise, it's very challenging to see, you know, children that need proper nutrition, and you can't provide it to them. You can help one from your own pocket, but you can't help everyone. So it is a challenge. And they come every day in big numbers with burns. And we also will need to exchange ideas on wound pain management. I think Ms. Victoria also came to the wound care room that we were using for dressing our patients. And basically, we don't use much of painkillers or pain management during dressing. So there's a lot of problem in that area, and a lot of crying and pains and all that. So we also think of, if we get the expertise, then we can share, exchange ideas on how best we can deal with that. And also physiotherapy and rehabilitation, also we are lacking behind. We don't have in-house physiotherapists or occupational therapists in the ward. So those are areas that we would love to focus on, and wound care, that is in general, and we can also focus on that. Yeah, just to say the few.
No, we appreciate that. I mean, like, because that gives us more varieties of area that we can focus. And when we started recruiting people, because we want to have, Mr. Victoria should have her own team of people who are she's gonna come and work with. So giving us different areas, like, I said, pain management, physiotherapy, and food, nutrition. So at least we can figure out those are the things that we need to address, and giving more people, adding more number of people that you can come and work with Victoria. So definitely we're gonna try and address as many things as you mentioned there, but most of the time they're interrelated. So if you're talking about nutrition and rehab, the child is not going to, their skin is not going to heal if they don't have a good nutrition or protein-based diet. So those things goes together. And of course, with the physiotherapy, if the child is in pain, more likely the child is not going to agree to do the exercise because it hurts. And then so if we can tag team and make sure we address that part in holistic, that will help that child to heal. And I know you talk about the challenge, some of them family might not have food from home. So is it this ambulatory, I wasn't there at that time. So is it this ambulatory services, means like they come in the morning, do the procedure, and then send them home at the end of the day? Or is this the unit that you keep the child there for 2-3 days, week to try and rehab so they eat from the hospital? What exactly do you do, Dr. Mem?
We admit all patients that will reach the criteria to be admitted.
Okay.
And yes, so those ones who meet criteria will be admitted, and they will stay in the ward till they're healed, almost healed completely. Okay. So depending on the size and depth of the burn, then some will stay 3 weeks, some will stay months. And basically, the majority of patients, the hospital provides some food, but not to every patient, especially for those who come from up country, that's who are not residents in Dar es Salaam, are given some food. And also that also has some own challenge when we can talk about it later. But majority will depend food from home while they're admitted in the ward. And we all know most of our environment here. So most of the time the food is not, balanced. And so we have we have some food that we can use, but has to be bought. It's we had some a surgeon from Ethiopia, and he came up with this a food ration that will be enough for every day for a burn patient. That is like mixing 4 eggs, bananas and avocados and some sugar. That will give you the mixture, depending on the body weight. The mixture will be like 1 cc is like it's like 1 calorie, So that has to be, the patient has to buy from the market all these fruits and eggs that every day, and milk. It's a mixture of eggs, milk, bananas, ripened bananas, and avocados. So that one will give you like 1 cc, 1 calorie. So it's like for a child who is like 10 kg, will maybe have like one liter per day. So that is like 1,000 kilocalories per day. They have worked on it, and it seems that is the most cheapest, but still it is a challenge for parents to buy that every day. Have a liter of milk, 4 eggs, 4 bananas and avocados every day. So that is also a challenge, and you have to have a blender to blend them, so it becomes like a milkshake. So that is it's a milkshake. So because you mix milk, yes, there's milk, so it's a milkshake basically. Okay. It's very sweet and the kids love it, but it is a problem to get it every day to the patient, and some can't afford it completely. So we end up just coming back, depend food from home, which is not balanced, and the wounds get delayed to heal, and other complication, the longer they take, the riskier it is, infection and all this. So, those are big challenges. Nutrition is a big challenge and all that. Yes.
So, Dr.
Of course,
Berman,
yes.
what is the TBSA criteria for admission?
We use the, it's like for children, it's like, above 10%, we will, we'll admit, bands around the joints, bands around the, perineum, whether it's electrical band, acid bands, facial bands, and all this. So, and this also applies to adults, which is about 15 to 20%. We'll admit them, and area around the hands, face, and inhalational bands. All these will be admitted. So we use the standard, standard protocol.
Admission. Okay.
Yes, international. That is we use, and fluid management. We use the same as it's used worldwide. Parkland or modified Brooks formulas, and we don't have problem with much of resuscitation because the fluids are there, as long as you can get the line. That's why on our request, we also wanted to learn more about central line placement, because most of these children who come all patient with burns, and we have most of the areas where you could get lines are burnt. So those are areas that we can get help, and from you guys.
Quick question. You mentioned the central line. So do you guys have the tubes or equipments to go with, and you just need the training, or do you need both?
Yes, the equipments are there. They're expensive, but they're there. The hospital provides. As long as you need to place a central line, you'll get a central line.
Okay.
The hospital is attached to the university, so we have a lot of residents.
Oh, okay.
Yes, so the training is there in the hospital, but depending on, so we have residents who are rotating in our unit. So whenever you guys when the training is, when you are down here, then the residents who will be around, they can get an opportunity to learn, and probably they'll learn more better, or the best way to do it. Probably they know, but it's not the best way. So yeah.
Do you guys have the ultrasound, like what to scan the vein or to press?
No, we don't have.
I mean, this child is already been banned. I don't think I want people to poke more than once.
Exactly.
Yeah. Oh God.
So I forgot about that. I think that is very important.
Okay.
Yeah, we can add on our list.
Of course.
So the K-wire device that you inquired about, I did call a company, and I sent you the measurements, or rather some of the specifications that he wanted. But then I called him back, and he said that that's not enough of specifications. So I'll write out another list of more specifications that he's needing in order to fulfill the need.
Thank you very much. I will do that when I get the list.
Yeah. So for the burn, I mean, I'm thinking because you have emphasized the training, almost everything it's discussed, the training. So the same thing we're probably doing way before we get there, some training, like it has started probably maybe April, because I think by then Victoria have already attended a conference somewhere. So then we can get some training starting like April, May, before we get there. By the time we get there, it'll be like people at least have some knowledge and pressing those things. Because I mean, definitely, I'm thinking if somebody's burned, they lost the skin, lose fluids, heat, and all this stuff. They need fluid, so they need access, and the access should be definitely those central line. And if you have the equipment, that's perfect. But we need to probably talk about the vein finder when we don't want to poke these babies more than once, or even adults. Yeah. So we figure out somehow, somewhere, and try to find good Samaritans to help us find those equipments. But that was very good, Dr. Raymond. I appreciate your time and explaining all those things. And I know, I'm sure Ms. Victoria is feeling at home in all this discussion, right?
Yeah.
Okay, just almost we're done. Ms. Kristen, I know you're here. We were supposed to have Ms. Clara, one of the teachers from Mnazini Mmoja Primary School in Dar es Salaam, the school that we are going there. So the one that has 800 kids. And you heard when we were talking about the health screening and then also vision screening where Dr. Vanessa is gonna go to the same school. And then so for the part of the teaching part, we are still going to do similar basic hallmark training for our pediatric population is the hand washing and dental hygiene. And then of course, we're gonna add the PE because we're gonna work with magnets, but still also we're gonna work with the kids there. They have a sports, two of the sports, let's see, sorry. So they have volleyball, which they also play with netball, and then there's football or soccer. So they have all those kids who are playing sports. So the same thing that we're gonna do for magnets with the teaching, so we're gonna do also at that school. So there'll be a bigger group going to the school because some of the people will be doing vision, some of the people will be health screening, some of the people will be teaching, and then some of the people will be doing the PE. So we're gonna have that schedule, and I'm gonna need your help to be able to figuring out to make sure we address all those areas. We are going to have, I know last time the first mission we went with you, we were talking about with the teachers. So usually the teacher wants the lesson planning skills, wherever. So you are going to get an opportunity to start talking to them probably in March, and then every month after that until we go there. So you have, I'm gonna connect you with Ms. Clara. So when we meet, then you can be able to discuss specifically for the training the kids needs education-wise. And then so if we can address ahead of time, we are going to try and do the school supplies, the same thing we did before. We're going to try and do the toothbrush, toothpaste, of course, yay. And then, of course, Ms. Catherine with her lollipop. So now she has to outdo herself again with 800 lollipop, maybe 1,600. Last year she did a very good job of 1,600, yes. So we're gonna put a challenge right there. So let's see if you can do 3 times. No, I'm just kidding. I'm just kidding, Kathy. But yeah, so we are going to do, for the school, it's gonna be almost like a bulk of number of people who are going to be there. Because the hospital is gonna be a little bit specialized in the sense that like the doctors who are going to teach there, the nurses who are going to teach, there's gonna be like specific classes like what Ms. Sinori, the nurse practitioner from Ohio, and if she has another nurse practitioner, if they go over there, then it's going to be like in the NICU, doing the training and stuff. Of course, some nurses will be joining them, and then some people will have people who don't have the medical background, but they can help with the logistics and help with the classes and stuff. So it's going to be a big group, but for school, it's going to be almost like 50% of the group that is going is going to be geared for school because the school is big and we have so many things to address. And this school does need help. Like it's not the same as in Chuka. It's not this. What do you call it? Kongwa was okay, but this one does need help. You're gonna see the pictures later when we start doing the fundraising and the recruitment for the school. There's a lot of things that are needed, and the teacher need help, and the student need help. So we are going to be able to do individual groups meetings to explain those logistics and focus specifically for raising money, raising funds, raising donation or collecting donation for specific area. So like Dr. Vanessa's group is going to be focusing on those collecting glasses and try to find whatever things that she needs. If we need to get funds to buy those acute screening, then we're going to need to have to find that group which is going to do that. It's going to focus on that part. The group that is going to be doing the school supplies, dental hygiene, and wherever, it's going to be focusing on that part. People who are going to the hospital with a NICU or OB, postpartum hemorrhage, we're going to need to raise money and get those equipment that we need. People who are going to ban area with Ms. Victoria, yes, focus on that group and raise money, and wherever we can address for what Dr. Mrema was talking about, we need to be able to address and identify things that we can do, or it's going to be within our reach, then we need to do those things. People who need the training, then there's people who are involved in training. We're going to start doing training in March or April, whichever is going to be the soonest, and when the education is identified, and then the location and how the mode of delivery is identified. So majority of them, I think we're going to be doing the Zoom, which is fine. we're going to have the Zoom and we're going to record it, and then all this education training is going to be shared in the YouTube. So then they can access as much as they can, and our counterpart in Tanzania, they should be able to help us to be able to use those training and or tell the other healthcare workers to watch those videos, learn, and then probably the next month when we have another topic, then people need to be able to learn those things. So we're trying to do those training even before we get there. So by the time we get there, we are working with our colleagues who knows already things that we expect, and then probably brush up and address the challenges that they've gone through to make sure we make it better and everybody know what they're doing.
I do have a question regarding the education part.
Yes.
Each of the subgroups that you talked about, the babies and the burn and the ophthalmology, all of those subgroups have a need for a nutrition part of it.
Yes.
Do you want to focus the nutrition part on any particular subgroups? Do you want to do a little portion for each subgroup? I mean, how do you want to focus the nutrition aspect of it? I've been talking with Ms. Teresa about the different grains and the different products that they might have available there, and how to do different combinations and things that they could get the most bang for the buck as far as the athletes and the children are concerned. I'm just wondering if that's going to be, if you're going to want to focus on that or focus more on the other issues.
So if we get Ms. Teresa to go with us, she's going to probably start doing the training way before then. And yes, so there is a burn area that they're going to focus, like what Dr. Rema was describing, the type of the diet that they're looking for. So then yes, if Ms. Teresa is there with us, definitely it's going to identify those areas. So if she's able to go with us and we can schedule her around, maybe Monday will be with Muimbili, Tuesday will be with the Buguruni, and then, not Buguruni, yeah, Buguruni. And then Wednesday will be with Mwananyamala, and then Thursday will be at school. So because she was already given those training before we get there, what type of food, whatever my plate, what type of food we have, either for the athletes or for school, we can distribute that way. But yes, nutrition is almost addressed everywhere. And
Right.
so, and also it's subset on everything. NICU babies, mom needs nutrition before baby's born. So I understand and I agree with you that nutrition is almost addressed everywhere else. And if we get an expert specifically for nutrition, like Ms. Teresa, then we're gonna make her, she'll be like rotating everywhere where she's needed for that topic. So let's say she has something to teach in for the kids. And yes, that day she may go to the school. The next day she might go to the NICU to talk to the OB, talk to the moms about the nutrition, and if she could have suggestions for Tanzanian food, what they need to increase for certain things, yes, she can go to the burn unit to talk to the parents what diet they need to see and what options substitute. Okay, let's say protein. I cannot afford meat. What type of food should I eat to be able to increase that protein for this kid who is need to heal? So all those things we can address that way by getting her useful on all those areas. But I agree, every area almost talks about nutrition, but what type of nutrition for an athlete, type of nutrition for the burn patient, type of nutrition for the labor and delivery mom, type of nutrition for the kids who are playing, at their school. So yes, she will be useful everywhere. I'm gonna stretch her to share everywhere.
I'll let her know.
Yes, she's needed. Tell her she's already given places to go.
Okay.
Yes, no, definitely we appreciate the person with the expertise in the nutrition, because we really gonna need to address those type of food, and she can help us to be able to find a substitute. Because remember, yes, my plate, it covers what things that can be done. Here in United States easily, but it has to be addressed in Tanzanian format. What type of food they have, what region the people live, and how can they access that type of food. So I agree.
Okay, well, my other question was, as far as I was speaking with Miss Jessica too, as far as her athletes on her soccer team, and the kids that needed specific more protein and things out of mixture, the grain mixtures and things like that. So how are we going to focus when we're meeting with the children at the schools? Are we going to focus on that and the grains and the proteins and the mixtures with that? Or are we going to do general umbrella lesson on
No,
nutrition?
it's going to be individualized. Almost it's going to be individualized for what the group we are talking to, which audience is going to be. So for school, remember for school, we may do 2 or 3 lessons in one day. Let's say the group in the morning, they can do hand washing. The one next week, you can do dental hygiene. And then in the afternoon, she can do the nutrition. The next day, she can, if she's going somewhere else, that's fine. But if she's going back to school, she can be in the morning the next day and then different classes. Because the time that we are there, they know we're going to be there. We're going to give them the schedule. They're going to know maybe this hour is going to be the volunteer, group of volunteers going to teach this. And then another day, whatever, if we're not doing in the afternoon that day, which is fine, then, you know, we have different activities. So we're going to have the schedule and we're going to know what exactly, where she's going and where she's going to be needed. And she's going to be focusing on the area that she's going to be teaching. If we say we are going to the hospital, acute area, what type of nutrition she's going to have already know what exactly she's going to teach that group. It might not be exactly the same. Maybe the athlete and the school might be similar, but for the school, the 800 kids, only 70 do the actual sports. So she might be focusing on general balanced diet versus increased protein or increased carbohydrates before or after exercise. So it's going to depend on where exactly which area she's going to go. And she will know way ahead of time because we'll be talking to this group even before then.
Okay, so it'll be several different mini lessons.
Yes.
Yeah.
Oh, yeah. Mm-hmm. Yeah, it's not going to be just a general, no, it has to be that specific that the kids should know what they have and what they can eat, or usually what they eat, and then what the substitute you can substitute. Because I mean, majority of them, of course, I would say probably 78% of the children eat carbohydrates.
Right.
Because that's what is available. So protein is lacking and these kids are growing. So what type of protein do they need?
Right, right.
So yeah, she will have enough time to discuss way before then. You talk to the teachers, talk to the coaches at the magnets, talk to the doctors. I mean, if she needs to talk to Dr. Mrema, we connect that. She will talk to Dr. Mrema about the brand unit and Miss Victoria there. So we will have more meetings, but it's going to be specific section meetings.
Okay. Thank you.
Thank you.
I miss you, my sister.
Hey, Dina. Hey,
Hello.
there. Hey.
Yes, doctor.
Yes. Do you have anything to say?
Oh, myself, I appreciate the ongoing process of coming 2022 mission at the Buguruni Health Center and at the Dar es Salaam in general. So I just say welcome. We are prepared to see you. Only that.
Okay, no, thank you. We are looking forward to it. So just to give, just to give a recap, it's like we do have Muhimbili Hospital, we have Buguruni Health Center, we have Mwananyamala Hospital, and then so and also we have the school, Mnazini Primary School, and we have Magnet. So that's almost the 5 areas. So we do have specific groups in each group. Yes, sometimes if your area of expertise can cross through the other areas, that's okay. We're gonna give a schedule. Everybody's gonna know where they're going because you have logistically, how you get there, how you come back. We have all those things squared away, but you're gonna know way before even there. Even probably before May, you know where you're going and what are things you do. So our goal is gonna be like, this was just an initial, so you can hear other areas, what you need to do. But also a lot of experts today, they're gonna start focusing on their areas so they can get what they need and start preparing for the training and the medical mission. So once you are in that area, then we're gonna expect you to be able to focus on bringing awareness. If you know the person who can fit well in that area, and I appreciate Ms. Catherine even offering to collect more glasses for Dr. Vanessa. That's excellent. The same thing, even if you are in a different group and you know somebody else who can benefit the different group, that's fine. We are all together. So it'd be nice, we can help each other. If we know somebody else who can fit very well with burn care, definitely offer that support to Ms. Victoria, so then we can address. We want to make sure when we go there, we've already started that process a long time ago and be able to be effective. And yeah, so it's exciting and a lot of work, but I appreciate every single person who showed up today and shared their expertise and willingness to help and take care of those people who are less fortunate than us and try to make their life a little bit better. So if you can go and impact one day for them and make it better, then that's what we need to do. Oh, yes. The iPhone person, could you raise your hand? Anything that you want to say, Ms. Catherine, Ms. Christine, Dr. Mrema, Victoria, Mr. Siakabe? Anything? Anybody?
Well, great meeting.
I'm just really excited to go and can't wait to meet everyone in person.
Good. I'm glad too. Dr. Vanessa?
No, I'm excited also and happy with the direction that we're going to go in, especially for the vision. I feel this way will be more effective and we can cover more ground.
Yes, I agree, and thank you for coming. Yes. Miss Victoria? No, you're muted.
Okay, likewise. I'm happy to be on the mission and also happy to be able to lend my heart as well as my experience to the need.
Thank you. Miss Catherine?
I think this is a great group of people and I can't wait to see all the great things we do in 2022.
Yay. Dr. Mrema, are you still there?
Yes, I'm here. Thank you, everyone, and thank you, Dr. Gabon, for inviting me. And we'll love to have you in Tanzania and share your experience with us. And welcome to Tanzania when time comes.
No, thank you very much for your time and sharing what the needs are, so we can be focused on what the needs is. So thank you. Thank you.
Thank you very much.
You're welcome. So bye guys, more to come. We're gonna be getting more emails, and once I finish this recording, I'm gonna send you. So if you wanna refresh it and you're bored somehow, you can listen.
Wait, 1 second.
All right, what?
How do we say goodbye, Victoria? Kiswahili. You're muted.
Why would you put me on the spot?
No, we discussed this morning, Victoria.
I would definitely have to look it up. You just hold on a second.
No, wait,
I'm gonna.
Remember, I told you I texted you this morning.
I'm gonna find it.
Oh, okay.
Give me a minute. It's Asante Sanya Rafiki. No?
No, that's
thank you very much, friend.
Oh, Tutanana Badai.
Ah, Asante sana. Tutanana badai.
Thank you.
Tutanana badai.
Tutaonana baadaye. Asante sana.
Dr. Vanessa, tutanana badai. There you go.
Okay, bye guys. Thank you. Be blessed.
All right.